Good morning, everyone, and welcome to this meeting of the Rural Pennsylvania Legislative Briefing. It's my honor. I am Representative Kathy Rapp, and I am definitely from rural Pennsylvania. I represent Warren, Forest, and Crawford counties, and we're very happy to be here and have the health centers do this presentation, this briefing. They serve some very underserved people in rural Pennsylvania. So I welcome you today, and I'm looking forward myself to the presentation. I have attended these briefings in the past with Representative Matt Baker, and finding and appreciate Representative Baker even more as I step in to fill the position that he left, and we certainly wish him well in working with the administration in Washington, D.C. And beside me is Senator Lisa Baker. And Senator, do you have any remarks?
Good morning. Thank you. It was a privilege to work in partnership with Representative Rapp, and we congratulate her on your new assignment, and we're happy to chair this briefing for both members and staff of the House and Senate. We certainly know that access to quality health care in rural communities is important. The work that you do is very meaningful, and you are the employers in our communities that have great impact. So I'm happy to be here joining Representative Rapp. I'm Senator Baker from the 20th District, and I represent Luzerne, Wyoming, Susquehanna, Wayne, and Pike counties. And I'm happy to have some of our folks here from northeastern Pennsylvania as well. So welcome. We look forward to your testimony, and thank you for the work that you do.
Thank you, Senator. We do have a few legislators here. Representative Rich Irwin is over here in the audience. And would you like to say anything, Rich? The area that you represent, you're welcome to.
Yeah, it's great to be here, and this is a very serious issue in rural communities, and I'm glad that our J.C. Blair Hospital from Huntington County is represented them here, so I appreciate taking the time to come down and testify today. Thank you very much.
Thank you, Representative. And behind us is Representative Tina Pickett.
Thank you, Madam Chairman. I am Representative Tina Pickett. I represent Bradford, Sullivan, and Susquehanna counties. And yes, we certainly need to keep the spotlight on the needs of our rural health constituents, and in particular for me, an interest in the critical access hospitals and their needs. So thank you very much for holding this forum today.
Thank you, Representative. And at this time, I'd like to introduce Lisa Davis, who is the Director of the Pennsylvania Office of Rural Health and Outreach Associate Professor of Health Policy and Administration at Penn State University Park, Pennsylvania. And Lisa will be conducting the meeting today. Lisa, welcome. And we truly appreciate all that you do for our rural citizens across the state. So at this time, I will be handing everything over to Lisa. Thank you for being here today.
Thank you so much. Thank you so much for that introduction. And I do very much want to welcome all of you to the 2018 Rural Legislative Briefing. And I am very honored to be able to meet for the first time Representative Rapp and to welcome her to her new role as the chair of the House Health Committee. We've been working with that committee for a number of years as we've been organizing these rural legislative briefings, and have found that to be a very beneficial relationship. And so we welcome the opportunity to work with you. Also want to extend a sincere thank you to Senator Lisa Baker for participating as the co-host for this briefing. It is because of the dedication of their excellent staffs that we are able to offer this briefing. And I also want to thank everyone who was on the Planning Committee. You will see all of those organizations represented on the front of your folder, which I know you all picked up your folder when you checked in this morning and signed in, correct? So we thank you again for being here, and also want to thank very much our presenters this morning. Today we're going to be discussing an issue that is of extreme importance in rural Pennsylvania, and that is being able to have access to high-quality primary care, inpatient and outpatient and acute care services for rural residents. Access to care is one of the most pervasive issues in rural America and in rural Pennsylvania, and so we are very fortunate to have an extremely solid safety net provider network here in the state, and so we are very pleased to be able to have representatives of that safety network here to talk about the work that they do. We will be focusing on the federally qualified health systems, small rural hospitals and critical access hospitals, and free clinics across the state. We had hoped to have someone here to talk about the rural health clinic program, but as all of you who work with programs know, that if you are working in a clinic or a hospital, there are emergencies that come up and you are not able to leave. And so Micah Gorski, who is with St. Luke's Miners Rural Health Clinic program, called me about 10 minutes before the briefing started and said, there is no way I can get on the road from Tamaqua to be down there in time. So we appreciate that he has some issues that he has to deal with, and it is important, of course, to focus on providing care to the populations that they serve. Representative Rapp, has anybody else come in who we might need to recognize?
Thank you, Lisa. Yes, to our right is Representative James. Representative, would you like to introduce yourself, please?
Thank you, Representative Rapp. Yes, my name is Lee James. I represent all of Venango County, which is, for those of you who haven't been to the west, is about halfway between Erie and Pittsburgh. We are definitely rural. Currently, we're served by UPMC Northwest, but we keep in touch with all the providers across the state. So I want to thank the panel for coming and testifying today. Thank you.
Thank you, Representative. And I also see staff from Senator Hutchinson's office. We thank you for being here.
Senator Brooks's office.
And Senator Brooks from Mercer County is also here. Thank you. Thank you, Lisa.
There are a number of activities going on here in the Capitol today, as I'm sure you noticed. And so there will be individuals coming in and out of the session this morning. And our two speakers are going to be speaking. And then, so please, if there are questions that you have for them, please ask them after their presentation, since they need to excuse themselves to go to a legislative meeting. But we're so glad to have you here with us right now. To talk about the role of community health centers in expanding access to care, we have Christy Bernardi, who is the CEO of Keystone Rural Health Consortia in Emporium, Pennsylvania, and Michael Coley, MD, who is the medical director of pediatrics for Keystone Health in Chambersburg. Ms. Bernardi, as the CEO of Keystone Rural Health Consortia, knows rural health well. She has been with the consortia for a number of years. She began her career as a licensed practical nurse, working for over 20 years in various positions, and then she served in quality assurance at Keystone Health Consortia and was promoted to the administrator in 2013. The consortia has been in existence for nearly 39 years and has three locations: a dental-only site, a medical-only site, and then a third site that combines both medical and dental services. Dr. Coley has been the Chief Medical Officer of Keystone Health since 2015 and the Medical Director of Keystone Pediatrics since 2004. He came to Keystone Health as a member of the National Health Service Corps, so terrific. It's wonderful to know that all of these programs work together, and completed the core service requirements in 2003, 2 years after coming to Keystone. His comments, and both he and Christy's comments, will focus on the important role that community health centers and federally qualified health centers have in meeting the needs of the underserved in Pennsylvania. So, Christy, I think we'll turn things over to you first. Thank you.
Thank you. Good morning, everyone. I want to thank you all for affording me the opportunity to speak today. I always welcome the opportunity to talk about community health centers and what we do, and also educate people on what a community health center is. I am the CEO of one of the approximately 300 community health centers in Pennsylvania, and collectively we serve over 800,000 Pennsylvanians. Keystone Rural Health, we have the same name. I just want to clarify something. We're both from Keystone Health. Dr. Culley's from Keystone Health. I'm from Keystone Rural Health Consortia. Two different entities, although we have the similar names. I am with Keystone Rural Health Consortia. We serve northwestern Pennsylvania, primarily serve the counties of Elk, Cameron, McKean, and Center counties, but we do draw from other counties such as Warren Forest. We have some patients from there. We have 7 locations in those counties. 3 of those are standalone primary care facilities. 3 of those are standalone dental sites. And then we have 1 co-located primary care facility, dental center, and behavioral health site. We serve last year over 4,500 patients with over 16,000 visits. We have, in rural Pennsylvania, we have 7 sites, but small. We do serve a lot of the people that would not have access to care otherwise because of our locations. We have been in existence since 1976, 42 years. And how Keystone Rural Health started was the same thing we're talking about today. A group of community members in Cameron County were concerned about access to care for the people that lived in the rural areas. So they formed a board, applied for a grant, and so began Keystone Rural Health Consortia. So the access to care is an ongoing issue even over the past 42 years. We've been lucky enough to expand our services so that we are able to serve as many people as we possibly can. I have been with Keystone Rural Health Consortia and in the community health centers for over 5 years. I did start as the QA coordinator. I have been a nurse for over 20 years, over 25 years to be exact. I did start as a licensed practical nurse. I went back to school to become a registered nurse. So my passion is for caring for people, and being part of a community health center allows me to do what my passion is, caring for people and ensuring that their needs are met and that they are given the best quality of care that they can get. As the CEO at a community health center, as with all of the staff that I work hand in hand with, we take great pride in our mission and the mission of community health centers. We serve those without access, we serve those with the inability to pay for services, and we do so with the highest standard of quality. And this is really what defines the safety net in general. This is the mission of all of what we do. I'm always asked to give examples of an example of what a patient, a specific case, or that epitomizes us as a safety net, and also talk about the challenges. And I have one example that kind of discusses both. Recently, we had a large hospital system that closed its dental services. Reimbursement issues, several issues that made that necessary for them, unfortunately. They gave the patients and their providers and staff 2 months notice that this was going to happen, leaving 8,000 patients without dental care. We are the only provider of Medicaid services for dental needs in the counties we serve. They were the only provider of Medicaid dental services for those patients. We were able, as the safety net, to recruit somebody fast with the help of a recruiter, and absorb those patients in a newly opened dental center in Kane, Pennsylvania, in McKean County. We just opened last week, and absorb them through our Johnsonburg Dental Center. Access to care, we were able to provide. Transportation for some is an issue, but we were able to get most of those people in as soon as possible, and a lot of those people had to get in for various reasons. So it really truly epitomizes what a safety net is. Getting those people without care that would be left without care, that is our mission, and that is what we do. The barriers that we face, the struggles that we face, transportation, of course, in rural Pennsylvania is always an issue. We started a provider, we hired a dentist without being able to fully bill for him, but we will eat that cost because the patients come first. They need their care. Credentialing doesn't happen overnight. We try to get it done as fast as possible. That is another barrier, struggle in Pennsylvania that we face. So we're getting there with him, but our mission is to serve those people, and if we have to eat some of that cost to do so, we will do so. Establishing, operating, and sustaining a community health center in rural Pennsylvania is an active, ongoing struggle. But it is within those struggles that it is important that we stay committed to the mission of community health centers and rural health care in general, that we stand up and fight, and that we go above and beyond to ensure that as Pennsylvanians in roles where we can impact this, that we are providing these services the best way possible for all of Pennsylvania. Any questions? Sure.
First of all, thank you for being here, Christy. And I will say that the dental issue in rural Pennsylvania, I see there are significant barriers for many of our folks in rural communities. And I'm happy to hear that you addressed some of that and what you're doing, because I know I live right outside of Warren, but and you know, our school districts are obviously stepping in the best they can to do screenings and, you know, checkups for kids, but the access to dental care is a real concern, and it's becoming even more of a concern for many legislators. We want our children to be healthy, and you know, a lot of that health does start with good dental care, because if we don't have the dental care, that can obviously cause other health problems. So when you were talking about the clinic closing due to lack of reimbursement, any suggestions for what we can do to help remove some of those barriers as far as dental care or any other care? I know that transportation is a big issue.
Yeah, transportation is an issue. Medicaid reimbursement for children in dental is fantastic. It's good. Unfortunately, for adults, it's not. You know, dental reimbursement in general for adults isn't as good in Pennsylvania as it could be. You know, dentures is a huge, huge need in Pennsylvania. You know, it has ties to the opioid crisis. It has ties to a lot of things. You know, people should have the ability to have teeth, not only for the purpose of eating, obviously, safely, but, you know, you go into a job interview with no teeth, and it's very difficult. People don't want to hire you. And there's no reimbursement. There's very little reimbursement for dentures in Pennsylvania. So we as even community health centers, you know, it's a big loss for us to provide those services. We actually had a huge loss, a $200,000 loss, by providing those services for dentures to our patients over the last year to make sure that they did have dentures. And that is a struggle, because as a nonprofit, and you don't have room for a $200,000 loss. So we are in the position as do we offer those services or do we not offer those services? And I do know that part of the reason that this hospital system did end up closing and their loss was because of some of their loss was attributed to the denture reimbursement. They also don't have, we have a PPS rate for reimbursement that they're not, other healthcare facilities don't have that opportunity, and this hospital system did not have that enhanced reimbursement. So that affects them. So there's a lot of issues that play a role into that. I do agree that getting to the children is extremely important. So what we've started, we hired 3 public health dental hygienists. We've got into the Head Start programs. We're in 7 of them right now, and we go into the preschools, and we do this free of charge, the preschools, trying to educate parents on the importance of dental health so that the rampant decay, we try to avoid that as much as possible in the children, and we feel that if we catch that early, we avoid a lot of the issues down the road. So being part of the Head Start systems has really helped that. We are also in, we just signed an agreement yesterday to be part of the Kane School District dental services, providing that it really is important in Pennsylvania. So we're trying to hit everything we can, but it really, the reimbursement has to change.
Thank you.
Christy, thank you for sharing that, and I too know many of our clinics go into meeting with and working with Head Start and pre-K counts and those programs, so I'm happy to hear you're doing that. Fred Jackson is here from Wayne Memorial's Health Clinic, and one of the things that they're doing in northeastern Pennsylvania is a partnership with the VA in service to veterans, because access for rural veterans is a problem, taking that long road trip to a federal location. Do you have any types of clinics or partnerships that you're doing to help address the issues with veterans? I think it's an unmet need that many people are not aware of.
I agree. And actually, yeah, we just started really researching the veterans population. We put information out there. We are lucky in our area that we have quite a few veterans clinics close to, but we do provide access. If they can't get into the veterans clinic, we make sure that they get into us, and we do get that information out there to the veterans. We've spoken at a couple veterans events, do a couple health fairs to make sure that they know that we're there for them if they do need it and they can't get into where they need to go. So,
I'm impressed with what Wayne Memorial's doing. It's an actual partnership so that they don't have to drive. So perhaps that's something you might want to look at as a satellite location. So Fred, I'm giving you a shout out in that way. And Senator Vogel has been the champion on our side of the building for telemedicine. Do you use much telemedicine? I know, Doctor, we'll hear that as one of your recommendations in your testimony, but talk to me a little bit about that. You know, we hear issues with broadband. Representative Pickett hosted a rural briefing in Susquehanna County related to that, and when you hear the need for healthcare access and our lack of broadband in rural Pennsylvania, is that something that concerns you, and what would you recommend to us related to telemedicine?
Well, any help you can give related to telehealth medicine would be so helpful. Broadband is a problem. There's not a lot of service up there in the rural areas. We are lucky in the sites that we do have most of our sites, I should say, have access to it, but 1 or 2 don't. I shouldn't say they don't. It's just not very good. And trying to find partnerships with people, not only the partnerships with the telehealth, but the cost of getting that implemented is huge. Trying to get, well, there's so much technical stuff that goes with it, running the T-lines and paying for that cost on top of it. So there are a lot of barriers with telehealth that I hope that we can get resolved so that it is the ease of getting involved with that makes the access for that much easier for FQHCs, because the need is there. People can't travel to the specialist, so they'll go without rather than, going to that specialist. We've been forced to pay for, an example of that is, we had a lady that needed to see a cardiologist, desperately needed to see a cardiologist. She didn't have a car, she didn't have the money to pay somebody, so we ended up paying the $200 bill to have her transported to and from each of those appointments that she needed to get to, but you needed to get to. So, we ate that cost so that she could have that care. Telehealth would have maybe, helped with that.
Thank you. Thank you, Madam Chair.
Senator Hutchinson and Senator Brooks are now in the room. Thank you for attending today. Do you have any questions or anything? Or?
Thank you.
Okay, thank you.
All right, Dr. Coley?
Thank you.
Thank you very much.
First of all, I wanted to thank Senator Baker and Representative Rapp for giving me the opportunity to testify this morning. And before I begin my own testimony, I just wanted to respond to the two questions. One is, in our community, we have a 1,000-person wait list for dental services at our own community dental center. It's over a year. And when it comes to telehealth, you asked what you can help with. Reimbursement.
Yes. Yes.
I'll leave it at that.
Thank you for the shout out to Senator Vogel. I appreciate your advocacy. Thank you.
All right, so I'm going to talk to you a little bit about something I'm passionate about, which is my role at the Federally Qualified Health Center. So I'm Dr. Michael Colley. I'm actually still a practicing pediatrician. I have patients scheduled today at 1. That's what we do in our role. We kind of wear a bunch of hats. But Keystone Health Center, which is different than Keystone Rural Health Consortium, we service South Central Pennsylvania. Was founded 32 years ago by our fearless leader, Joanne Cochran, in order to meet the health care needs of the migrant and seasonal farm workers of South Central Pennsylvania. Although its beginnings were humble, Keystone Health saw only 500 patients its first year of existence. Its mission was great. And within 5 years of its inception, Keystone Health had opened its doors to all of the medically underserved in Franklin and neighboring counties, not just the migrant and seasonal farm workers. And by offering free or low-cost health care to the under and uninsured, Keystone Health Center and other federally qualified health centers provide an access point for medical services to those who are most in need. Previously, before FQHCs came into existence, or where there are no FQHCs, these patients clog our emergency rooms or they go without care. These are the patients that most physicians would prefer not to see, unfortunately. Under Joanne's stewardship, Keystone Health has grown exponentially in both size and scope. I think we're either the second or third largest FQHC in the state. Through federal 330 grant funding and enhanced reimbursement through the PPS payment system, Keystone Health has been able to add service lines to help meet our community needs. In addition, because of Franklin County's designation as a health professional shortage area, we've been able to recruit providers through the National Health Service Corps and build a quality physician network. If you're not aware, physician recruitment to rural Pennsylvania is an issue that many people struggle with. As an FQHC, we have certain advantages, but still it's an issue. So currently, Keystone Health service lines include family practice, internal medicine, OBGYN, pediatrics, dentistry. We have a school-based health center, an urgent care, infectious disease and HIV, behavioral health, crisis, audiology and speech, pediatric occupational therapy. We have an STD clinic and a freestanding pharmacy. Last year, Keystone Health saw over 50,000 unique patients and had over 210,000 total patient visits. Our county has about 150,000 residents, so we serviced about 1 out of every 3 residents of our county. And like many FQHCs, we are ingrained in the culture, the economy, and the medical services of our community. Many of our service lines are unique and unduplicated in our community and are integral not only to the patients, but also for our local community hospital, because we provide a lot of the inpatient coverage for our local community hospital, which was Summit Health, but was recently purchased and will be WellSpan Summit. So I personally came to Keystone Health 17 years ago, as was mentioned, as a National Health Service Corps scholar, right out of my pediatric residency at Cincinnati Children's. And had it not been for the National Health Service Corps, I likely would have ended up, like most of my classmates, practicing in a larger suburban community. A little anecdote, Cincinnati Children's at the time was the second largest pediatric residency program in the country. We had 39 graduating pediatric residents, and this was 17 years ago, I was the only one going to a rural community, doing both inpatient and outpatient medicine. So times are, doctors like us are becoming dinosaurs. However, after coming to Keystone Health, I quickly realized that my passion was to help care for our most vulnerable populations. And despite completing my National Health Service Corps obligation 2 years after my arrival at Keystone, I'm still here 17 years later. And now I'm the Chief Medical Officer at Keystone for all service lines. And I could tell many stories of how Keystone Health was able to positively impact the health care of our underserved populations, but I want to tell the story of one particular patient that I think is a poignant example of the importance that Keystone Health provides, and as do all other FQHCs. So in November of 2017, Keystone Health, we held our second annual free diabetes health fair. And at that health fair, a 49-year-old Hispanic woman named Judith came. Judith was, and her ethnicity really is unimportant, but she was an existing patient of our internal medicine practice. She had a litany of medical issues, including hypertension, type 2 diabetes, depression, obesity, the list goes on. And although she had health insurance, she fell into the category of underinsured, as she had a high deductible and was unable to afford many of her medications. So as a medically complex patient, who wasn't the most compliant, she would frustrate her physicians because she didn't follow the medical regimen that was prescribed, because she didn't have the money to do so. Her English was poor, her resources were minimal, but because we provided free screening and translation services at our health fair, she was energized to learn more about the condition. And I was, although I'm a pediatrician, I participated in the health fair and helped coordinate it, so I was there. And one of the serious complications of uncontrolled diabetes is a condition called diabetic retinopathy. It's actually the leading cause of blindness in adults. So we had partnered with one of our local ophthalmologists to provide remote retinal screening, so telehealth basically. So we took pictures of Judith's retina and transmitted them electronically to a local ophthalmologist who can interpret them and see if she had any signs of diabetic retinopathy. Shortly after the health fair, I left for a conference in Las Vegas. And while sitting in one of the conference sessions, I got several urgent texts and emails from the ophthalmologist about Judith, saying that there was an issue. So I left the conference and talked to the ophthalmologist, and he said, you know, she's about to go blind. Her retinopathy is so progressive that if something's not done urgently, she can lose her sight. So we got her into treatment. We referred her to this ophthalmologist. Now, the treatment for this involves injections right into the eyeball to help prevent the spread of this disease. They're incredibly expensive, certainly beyond the means that Judith could afford. We explained this to the ophthalmologist, and look, you know, this is part of our mission. I know it's not part of your mission. And he agreed to care for Judith using the same sliding fee methodology that Keystone Health provides. So in the end, Judith's vision was preserved because of Keystone's existence in our community. I believe wholeheartedly that in the traditional medical service fee-for-service model, patients like Judith would be ignored or fall through the cracks due to her lack of resources and all of the other social determinants that she had. Because our mission exists solely to care for patients like Judith, we thrive when confronted with the challenges of her many social determinants. In addition, our presence in the community is a call to action to other community providers, like the local ophthalmologist we partnered with, to provide her with a reduced fee schedule. And whether you believe that access to health care is an inalienable right or not, our patients and the patients of all FQHCs in the Commonwealth and the nation are grateful to have quality local care that is affordable. Thank you.
I just have a comment. Thank you, doctor, for being here. My sister has to have those injections in her eye, and I accompanied her once, and it's not something I would want to do.
Very
but
pleasant, no.
I do have a question, though, as far as recruitment to rural Pennsylvania. Any suggestions on how we go about that legislatively to recruit more physicians, dentists to rural PA?
No, and it's a real issue. I mean, this is something that, in the 17 years I've been in rural Pennsylvania, I've asked myself that question daily, and for us, as an FQHC, we have certain advantages because we can rely on National Health Service Corps scholars. We can rely on J-1 visa physicians, whereas, our local hospital doesn't have that same ability. But even with those additional advantages, we struggle with certain specialties, particularly psychiatry, where trying to find a qualified psychiatrist who wants to devote their lives to serving rural Pennsylvania is extremely challenging. I wish I had the answer. I mean, it's a very difficult question, and I think physicians are looking for a certain community to practice in, and for many, it's not in rural Pennsylvania, unfortunately. I will add one more thing, that programs like the state loan repayment program are absolutely essential to continue. When I completed my NHSC obligation, I went through the Pennsylvania State Loan Repayment Program as well. And, those programs are critical to help alleviate some of the debt that physicians have.
And I would like to add on, that's how I was able to recruit a physician, was through the Pennsylvania Loan Repayment Program. So, keeping that funding, that level funding, or even putting more funding into that program is really essential to ensuring that we are able to recruit primary care physicians and dentists to the areas. We recruited for 2 years before we were able to find him, and it was because of that loan repayment program that we were able to retain him, too.
Hey, just a comment. I actually heard a story today at the breakfast that one community actually put an ad in a hunting and fishing magazine to recruit to rural Pennsylvania, because if you like to hunt fish, if you like clean air, clean water, come to Pennsylvania. Hiking, biking, whatever. So thank you for your dedication and what you do.
Thank you.
Doctor, thank you very much, and thank you for sharing that story about Judith and the outcome that was positive. One of the things that we are grappling with here is the opioid crisis, and if you could just take a moment and talk about your experience in a rural setting, and with an eye toward some of the recommendations that we should be looking at that can help provide treatment, access. It's a complex issue, and clearly one that we're all grappling with. But I just from your perspective, what are you seeing? We got the results of the study about neonatal abstinence syndrome in babies, and not only is that a concern for what we're seeing in these children, but what that means for their future, whether they will then become part of the system through early intervention, and so many of those kinds of things. So if you could tell us what you're seeing on the ground.
How much time do I have? Because I'm glad you asked the question. It's a critical question. It's very complex, as you mentioned. Just a couple thoughts, just kind of off the top of my head. One is access for these patients is absolutely critical. You have a very narrow window with most of these patients where if you can catch them at the moment they're willing to accept help, then you need to get them in for care at that moment. And the number of available treatment centers that are willing to accept patients, especially the under and uninsured, is it's challenging. One of the issues we grapple with, and we actually had a question and answer yesterday with the new secretary of the Department of Drug and Alcohol Programs. But one of the issues we struggle with is that we have licensed therapists who are willing to provide drug and alcohol counseling, but can't because we're not a licensed drug and alcohol facility. So one of my recommendations would be is to really look at the cumbersome regulations that are in place to provide drug and alcohol counseling and start to unwind them a little bit. Make it easier for people who are qualified to provide drug and alcohol counseling, because like I said, if you have that patient, take advantage of that moment. The other comment I would say is that communication and information sharing is critical. So I personally deputize our EMS providers in Franklin County to have naloxone or Narcan available, and they're doing the Leave Behind program now. The issue I have, and I'm supportive of it, I deputize it, so obviously I'm in favor of it, but one of the issues I have is that there's no effort we can revive and revive and revive. There's no effort to get these patients help. If there was a way that we provide what's called an ESPERT. We have ESPERT capabilities at our center, which is screening, brief intervention, and referral for treatment. So we have people who dedicate their lives to getting patients in for care, getting them in for treatment. That's all. They're basically case managers who they're just looking to service these patients. Yet we don't know who they are. We don't know who these patients who are being revived are because we don't have a network in place to be able to share that information. So I think information sharing and looking at the regulatory requirements to be a licensed drug and alcohol facility are two things that have to be taken seriously, or else we'll sort of be stuck in the same cycle.
Thank you very much. And obviously, you must also use nurse practitioners and others to help in the delivery model. Do you have any additional recommendations for us related to that?
Well, that's a loaded question. We do use advanced practice practitioners. We have physician's assistants and nurse practitioners. I'm actually married to a nurse practitioner, so I understand their value, and they play an absolutely essential role in rural health care delivery, in the rural health care delivery model, and being able to provide access to patients who otherwise would go without.
Well, thank you both so much for your comments. And I know that you do need to excuse yourselves in a few minutes, so we really appreciate you spending some time with us, and thank you for all of the good work that you do.
Thank you for having us.
Thank you.
Thank you. Our next speaker is Adam Dim. Since July 2017, Mr. Dim has been employed by UPMC Pinnacle to serve as the president and CEO of J.C. Blair Health System in Huntington, Pennsylvania, where he served as the chief operating officer from 2015 to 2017. He has been with UPMC Pinnacle since 1999, and he has an in-depth knowledge of healthcare in his roles as an emergency department technician, systems analyst for emergency services, business manager, and director of strategic management services. Mr. Dim's comments will focus on small rural hospitals and critical access hospitals. So thank you so much.
Thank you. Very excited to be here. Thanks for taking the time to invite us and hear what's going on in rural healthcare. I'd like to thank House Health Committee Chair Kathy Rapp and Senate Health and Human Services Committee Chair Lisa Baker once again for inviting us here and for hosting this briefing. Also like to thank the Hospital and Health System Association of Pennsylvania and the Pennsylvania Rural Health Association for the opportunity just to represent rural hospitals. As Lisa mentioned, my name's Adam Dim. I am the president and CEO at J.C. Blair. I was born and raised near Mifflintown, Pennsylvania, a small rural community in Juniata County, and was fortunate enough to be able to move back there after college and am raising my family in central Pennsylvania. So very connected with rural communities and rural health care at the same time. I did start my career at Pinnacle Health and got a very good perspective of a more urban health system before I was able to go to J.C. Blair and start to work with a rural community as a healthcare leader. And certainly some differences, many problems the same, but the strategies and many of the things that we've just talked about here are so pertinent and so important to our success. J.C. Blair is a sole community hospital. We're not a critical access hospital, but we're pretty much a mirror of most critical access hospitals. We're 62 beds, 13 of which are behavioral health inpatient, a nonprofit community hospital, the only hospital in Huntington County, much like many of the other rural communities. And it's a county of about 41,000 residents, spanning over 895 square miles of mountainous land and farmland. No public transportation, limited cell and broadband service, and I'll touch on that a little later. We're proudly the home of Raystown Lake, as many of you probably know, Juniata College, and 2 large correctional institutes that we work closely with to take care of the inmates there. And Huntington County comprises the 30th and 34th Senate districts served by Senators John Eichelberger and Jake Corman, and the 81st House District served by Representative Rich Irvin, who was here a little earlier. So I'm glad that he was able to make it. So similar to most rural hospitals, J.C. Blair is working hard to deal with the economic realities and transformation in our industry by streamlining care, improving quality, and increasing accountability. But we need your help as you consider the 2018-2019 state budget and various healthcare legislative and regulatory policies that impact Pennsylvania hospitals. Many of the ones I'm going to go over we touched on, which is fantastic, and I'll just basically add my answers to a lot of those questions. The first thing I wanted to just talk about was the quality care assessment funding. It is absolutely critical for our success. The outpatient, inpatient supplemental payments that we receive, our OB funding that we have. We do have a maternity unit, a labor delivery service where we deliver around 200 babies a year. It's a small program, but very essential for a rural community. And the funding that comes through the quality care assessment program is essential. That's the only word I can come up with. Very, very important. And it has about a $2 million impact to us at a $58 million organization. That's rather large. So we just encourage you to continue that funding. We understand there's some of that allocation being considered to be moved, and we would just really encourage you to keep that to end up in direct patient care as it's so needed. The second topic is telemedicine, and I got to tell you, from a rural community, technology is an open door that we don't want to miss for rural communities. I believe personally it can bring access to rural communities like we haven't ever had. The potential is there, the technology's there, the ability to connect to practitioners that have a little bit of capacity somewhere else that can connect to rural communities for that hour, 2 hours, 3 hours a day could transform rural healthcare. Infrastructure is a necessity. As we talked about, the broadband, that's a limiting factor right now. And then the payment and reimbursement for those providers is obviously the second piece. But I'm really excited about where that's going to go. I think over the next 5 years together, we're going to figure it out and we're going to get it right. And as the doctor described, access is really the key. And if we can get providers and clinicians from physicians clear down to social workers engaged and have the capabilities to use telemedicine, we're going to have access, like I described, that we haven't ever seen before in rural communities. Maybe back to the 1960s when the small community had their doctor that everybody knew and saw. That might be a parallel. But we definitely have a great opportunity there. We benefited from telemedicine tremendously at J.C. Blair. We have great stroke care. We're connected with UPMC Pinnacle for that emergent situation where folks come into our emergency department. We're able to care for them with a highly qualified individual from UPMC Pinnacle to guide and direct the process, and then make a decision whether they could be cared for there locally or if they do need to be transferred out for a higher acuity treatment. Primary care is essential as well. As I described in my first scenario, it has a lot of potential to create more access to primary care. And in specialist care, we're already working on, we have rheumatology, endocrinology, infectious disease, wound care. We've been working with UPMC Pinnacle on those programs for the last few years, and it's certainly impacted travel times for patients. They can stay close to home and have access to that. The third point that I'd like to make is around the opioid crisis, and I actually think it parallels, and actually telemedicine's a key, right? So it's access to the right provider at the right time in that critical moment. The rates that we've seen in Huntington have gone up over the last 3 years. Every time it happens, every time there's an overdose, it's a family member, a friend, or a neighbor of somebody in our community. Because it's such a small community, it impacts our community immensely. We are very, very supportive of focusing on an outpatient solution. I just want to emphasize the point that all good evidence points to voluntary entry into treatment as the most effective road to recovery. There's no published medical evidence that shows involuntary treatment for opioid abuse disorder works. In fact, there are concerns that the addict may actually be at a higher risk for overdose after that involuntary period. So as the physician next to me spoke about, it's that critical moment when they're ready for help and they've been through that situation. We don't have the inpatient capacity. Most rural communities don't. But what we've started to work on, I'm really excited about, and I think it has a lot of potential to be a good solution. We're actively partnering with our local Huntington County Prevention Network collaborative, which includes our Tri-County Drug and Alcohol Commission, to implement local strategies. We've secured a grant to purchase and place additional drug take-back boxes throughout the county, work with medical providers to assess opioid prescription practices, which is really key, and professional education with our family practitioners, our specialists, our orthopedic doctors. But then he touched on it, implement the warm handoff and the screening, brief intervention, and referral to treatment programs in the emergency department. And this is where our focus is. It's that coordination between our emergency department, our EMS community, and those folks that can take the warm handoff within 24 hours and start the treatment process on an outpatient basis. We feel it has a lot of potential. We have a great team that talks every week. We have a status call on the grant and the project, and we are actively working to see if we can impact the results on that through that program. And then additionally, I think the key for success in rural communities in all chronic disease management, similar to opioid crisis, is the community engagement. We've got to stop thinking about the hospital as the only solution. We've got to partner with every entity in the community that can work with us to take care of ourselves and take care of our neighbors. So we're really putting a big focus on that right now in Huntington, connecting with the churches, the civic organizations, putting together community health worker curriculums and education so that we can really get more and more people engaged with caring for the community and not just the few resources that the hospital has. Lastly, I'd just like to touch on recruitment and retention, as we talked earlier. Absolutely a challenge in rural communities. I like the Fishing and Game Commission advertisement. I'm certainly going to try that next week. But the The loan repayment program, please, 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 whatever you do, continue to support that and enhance it would even help. We have partnered with a federally qualified health center in our community, so we're able to take advantage of some of those provisions as they recruit folks, but the hospital's limited on the benefits that we have. So anything you can do to make that more flexible, because obviously we're trying to recruit to care for the same community. Next is along the lines of telemedicine, the reimbursement to continue to allow specialists from outside of our area to have reimbursement to provide care to folks in our rural communities. That would be another key. And then lastly, advanced practice practitioners, professionals, they are so important. And I think we're just starting to realize that in Huntington County. We were a little late in the game, and it's developing quickly, and we've created a lot of new access using nurse practitioners and physician assistants, and they do a great job, provide great care, and have made a big impact. So in closing, I want to thank you for all that you do as a public servant. It's been an honor for me to address these critical issues with you on behalf of all rural hospitals in the Commonwealth, and I'd be glad to answer any questions you might have.
Thank you for your presentation. It was very informative. We met with some of our local hospitals just a couple weeks ago, some of the area legislators. And you talked about the need for communities to come together, regarding the opioid crisis, and I absolutely believe that, and there is that issue of voluntary, involuntary. And I definitely believe that the churches, all of our human services, the one group that you left out when we talk about voluntary and involuntary is law enforcement. And I was able to go to a big presentation in our county with law enforcement, a local psychiatrist, and a primary care physician who's doing a lot of work and treatment. And so the hospital's understanding of involuntary is one side of the issue, but law enforcement in the county that I represent, the district attorney, we have a drug treatment court, so I guess you could say when the DA says you're either going to drug treatment or you're going to prison, I guess you can say that you're going to voluntarily say that you're going to drug treatment. So, but just saying that, I understand, that the hospital association and hospitals, yes, we want people to volunteer to go into treatment, but sometimes law enforcement says you will. So from your perspective, working with law enforcement, do you see that different perspective? And I'm sure in your county that law enforcement they obviously are. There's even our Attorney General here in the state of Pennsylvania. He has been to, I think, every single county. He was in my county talking with law enforcement and human services. So, and there's obviously a need for more behavioral specialists, mental health beds, and just so. Do you see that different side of voluntary, involuntary from law enforcement side?
Yeah, absolutely. It's a great question. So we are working with law enforcement as well on this grant, and they're participating in the conversation. I think it's a collaborative approach. I think it's the solution. The solution will vary on the situation, but if we can build a robust outpatient program that gets great results, that will be so inpatient would be the exception, not the rule, right? It would be the last alternative. It would be the most significant case. But if we've got a well-oiled machine that's working well on an outpatient basis, and that meets the needs, I think we'll see that conversation be less and less. But we've got to figure out how to be timely and attentive and be able to act quickly and effectively on the outpatient program, so that the only option isn't then to end up in an inpatient situation. So I think it's, to be determined, but I certainly appreciate their difficult situation that they're in, and we'll continue to work through that with them, to have confidence in the program we put together so that it is a good solution and they won't have to end up in an inpatient setting.
Do you see that there is a need for more rehabilitation centers across the state of Pennsylvania? I actually have a state hospital in the county, and they used to serve around 3,000 people. I'm not advocating that we put everybody back in the state hospital, but there are mental health beds that I think maybe could be maybe re-looked at, re-evaluated to turn into rehabilitation beds. Just your thoughts.
Yeah, it's tough to answer. The easy answer is yes. But I think historically maybe the yes is why we struggle financially today, right? So the hard answer is probably more effective and more efficient answer and takes a lot of work. But we've got to figure out how to drive the cost down at the same time. And, it's an issue everywhere. It's an issue urban, rural. So I think we owe it to ourselves to work really hard to figure out new, creative, innovative ways that will get the best results, make sure quality is better than it's ever been, but at the same time, the cost is much, much lower than just saying yes to a bricks and mortar and inpatient facilities.
Thank you.
Yeah.
Thank you so much for your testimony. I will share your quote with Senator Vogel about the open door that we don't want to miss on telemedicine. I'm sure
Thank
he
you.
will utilize
Absolutely.
that in his advocacy. I have several critical access hospitals in my area, and one of the challenges for them is the patient mix, which is high Medicaid, high Medicare. In some cases, at one point, it was about 85%. So when you're talking to us about the patient mix, we look at the level of funding you receive through the supplemental hospital assessment. If we're asking hospitals like you to give up more to come to the state's bottom line, what does that mean to your patients? We're not increasing your reimbursement levels for caring for those Medicaid patients, and how do you see that? And I know you're advocating very positively for us to try to eliminate the $130 million extra, that $350 million that the governor has proposed. So what does that mean to you? And I look at my critical access hospital, I know it is a significant impact.
Yeah, it's truly the difference between keeping inpatient services in rural communities and not. We're working closely with Dr. Lauren Hughes over here in the corner on the PA Rural Transformation Project, and really, I believe that starts to get at the root of the problem and a solution that has a lot of potential. We've got to maintain services in rural communities, one, because it's the economic driver for that community to have a hospital, and second, all of the folks that live in that community need care locally because they won't get care if they have to go too far, and then that will be a terrible ripple effect, I think, over 5 or 10 years. So the solution is certainly make sure we're paid enough to keep those services, but ultimately, back to my last comments, how do we innovate to decrease the cost of providing great care? And I really truly believe a lot of that is keeping them out of the hospital inappropriately, investing in more outpatient services. Telemedicine and broadband brings an open door for rural communities because it starts to provide us ways to care for those folks in rural communities in a lower cost environment and absolutely achieve just as good a results, if not better. So I think the answer until we figure it out, if funding gets cut, the curve of closures will just exponentially go off the chart, and that would be devastating to our communities and our country. So we've got to pay attention to it through the transition, but we've got to get started working on a new solution.
And I was intrigued that you are one of the rural hospitals in the global budget approach, which I know Dr. Karen Murphy had advocated when
Yes.
she was the secretary. And
For sure.
there are a number of my hospitals interested in that. So
Yeah.
I think looking to the future, that certainly is important. Senator Brooks had to leave for another meeting, but she was interested in how you cover and take care of pediatric patients in your community. She's very concerned that we're not strengthening pediatric care in rural communities, and I don't know if that's something that you're seeing, or is it something that you're trying to address?
Yeah, great question. So we still have OB services, so we deliver babies, so we're required to have pediatricians to be there when the babies are delivered. So one upside to continuing to deliver babies in a small community is we have a pretty robust pediatrician network. Speaking for many of the critical access hospitals that don't deliver anymore, I could see how it is a significant issue. But what we've talked about, just in our community, is the importance here again of telemedicine, access to those specialists, and then also primary care, so family practitioners and your nurse practitioners that work with them, to have a collegial relationship with the experts in pediatric care somewhere, so that you're following best practice, you're making sure that you're doing all of the right things that pediatric patients are receiving in more urban areas, but the nurse practitioners and family practitioners are fully capable of delivering the care in our rural communities. They just have to be locked in with the experts to make sure that they're getting the latest and greatest and anything that changes in the research. So I think it can be done well. Again, it's about access, so they got to be able to get to the appointment. They have to be able to be case managed and care managed and have somebody following and looking after them as a patient while they develop. So.
Just one final question. We met with some school superintendents and school board members, and the issue of children and behavioral health as an unmet need, and looking at how do we create that care model that connects the school to the hospital, and what more should we be doing to help provide that level of access. And they likened it to, we're talking school security, which is very important, school security about metal detectors and things of that nature. They believe school security is the mental health security of young children, and that access is something that we should be looking at in a better way. So I'm not sure what your network or relationship is with your local school districts or how you're connecting that, but it seems to me that we need to be focused on that as well.
Thank you. Great question. We work very closely with our schools, and the physician that was next to me talked about unwinding the regulations to enable and empower licensed clinical social workers and counselors to be caregivers, really truly deliver care in these rural communities, and then help us get paid something for it to afford them. We have an integrated behavioral health program where we are locked into our family practices and have warm handoffs from the family practitioners. The program could easily be extended to the schools and the school nurse, right? So we've got the right skill set and we've got the right program in place, but we got to figure out how to pay for it to expand it. That is absolutely a solution that could help on a real-time basis. And again, with telemedicine, where regardless of where they're at, they could reach out, have an intervention, have a discussion with that qualified individual. In rural communities, you could take care of, our entire county with 4 or 5 individuals, touching base with each of those schools. So I think there's a lot of potential with our integrated program, and that's a model that's out there nationally and through the state. But we got to loosen up the regulations and help us fund that. And it's not big dollar amount, right? It's just loosening up the red tape to make it happen, so.
Thank you so much. Your testimony was very valuable.
Thank you for having me.
Appreciate it. Thanks.
Thank you. I'd like to recognize Representative Judy Ward. Representative, did you want to say anything as far as an introduction? Okay. Thank you for being here. And also, Representative Knowles was here, and he had to leave for another meeting, so thank you.
Adam, thank you so much for your comments. Cheryl White is the Executive Director of Center Volunteers in Medicine in State College, Pennsylvania. And she has been the Executive Director there since 2010 after serving on the Board of Directors. Prior to working with CVIM, she worked at Health South Nittany Valley Rehabilitation Hospital as a physician liaison and is also an experienced project manager in healthcare construction. And her comments are going to focus on the absolutely critical role that free and volunteer clinics play in meeting the needs of uninsured patients. So, Cheryl, thank you so much for being here and for your comments.
Thank you, Lisa. Thank you, Representative Rapp and Senator Baker, for hosting this meeting and allowing me to be here today. I serve on the Board of Directors of the Free Clinics Association of Pennsylvania, so I'm here today on behalf of those clinics. Free and charitable clinics are safety net organizations providing quality health care services to economically disadvantaged individuals, typically uninsured or underinsured. Using volunteer staffing models, free clinics provide a range of medical, dental, pharmacy, vision, and/or behavioral health services to those who live or work in their communities. This volunteer model works efficiently and allows us to provide multiple dollars of care in services for every dollar donated. Clinics are typically started by a community where a health care need exists and are primarily community funded, and most receive little to no state or federal funding. Nationally, 1,400 free and charitable clinics see over 2 million unduplicated patients with the help of 190,000 volunteers. In Pennsylvania, there are 63 free clinics located in 24 counties, helping to care for the 8% of the population that it's estimated remain uninsured. Again, clinics form to meet the community need, so there are clinics located in counties where there are no FQHCs or no CHCs, and there are clinics located in counties that are served by multiple FQHCs. For example, Chester County has multiple FQHCs and has 2.5 free clinics. Free and charitable clinics form relationships with other local safety net agencies so that the holistic needs of the patients can be addressed, not just the immediate physical health care needs. We recognize that patients are more than just their disease status. Their health is impacted by where they live, how they obtain or don't obtain their food, and other socioeconomic situations, including drug and alcohol abuse, domestic violence, and mental health. Over 80% of free clinic patients are employed, most of them working multiple jobs where they either don't qualify for health insurance or they can't afford the premiums. Clinics typically use an income requirement of at or below 250% of the federal poverty guideline, although some clinics now go up to as high as 300%. Since the implementation of the Affordable Care Act, most clinics have seen an increase in demand for their services while seeing a decrease in donations. My clinic, Center Volunteers in Medicine, located in State College, provides free medical, dental, case management, and prescription assistance to those who live or work in Center County. Each year, we see approximately 1,000 patients across our 4 service areas with no income stream other than our donations. We currently receive no federal funding, no state funding, and less than 1% of our almost $1 million budget comes from Center County through the State Human Services Block Grant Program. Since the implementation of the Affordable Care Act and the expansion of medical assistance in Pennsylvania, my clinic has seen a decline in the demand for medical services. Our dental clinic, however, is another story, with over 1,200 people qualified for services and waiting for a first-time dental appointment. Several years ago, when our local women's health clinic closed, there was nowhere in Center County for women to turn who were uninsured, who needed services. So we started a women's health clinic to step in to address their needs. We have recently added an integrated behavioral health clinic 1 day per month to try to address the unmet mental health needs of our patients. So we are an example of how clinics morph within the community to meet the community need. Free and charitable clinics are an important part of the healthcare landscape in Pennsylvania, and every day we continue to stand in the gap for the uninsured. So thank you for having me today.
Thank you. I've worked with Dr. Susan Sardoni, who founded the Volunteers in Medicine Free Clinic in Luzerne County, and if you could just talk to us a little bit, obviously getting the equipment and all of the needs that you have, have you had, in terms of where you received that from, or grants, is that what you have to rely on solely?
So a lot of free clinics start out of either a hospital or a church, and start by a group of people getting together with a lot of passion, and they get together and they open a medical clinic. And medical for primary care, you need an exam table, a stethoscope, a blood pressure cuff, and then they realize there are all these other needs out there like dental and everything else that are much more expensive. So most clinics rely on their community partners, the hospitals in our area. We do a lot of grant writing. We just redid our dental clinic with a grant from Patterson Foundation. Things like that as far as equipment. Behavior, like our infant behavioral health program that we're so excited about. We were able to start that because a group of volunteers from the community, psychologists, licensed professional counselors, happened to come together at the same time. So right now that program is costing us next to nothing. However, we need psychiatric care to go along with that, and so now we have an expense there. We have a psychiatrist who's working with us, but we don't have the dollars that we need to pay someone to help us with that program. And so now we start to look for money. We are very creative. So
you mentioned that with the Affordable Care Act, your donations went down?
Because people think, well, now everybody has health care. So why should I fund the free clinic? Because everyone has health care.
And what percentage of your patients do have, whether it's Medicaid expansion? Do you see many people with Medicaid expansion?
So our patients,
Coverage?
to be a patient at my clinic, you can't have insurance.
At all?
At all. One of the things our case managers do is look for insurance for patients, because if we can get them insured, they come out of our clinic and go into the regular healthcare world. So we are also certified application counselors for the marketplace. That's something we do. We do COMPASS applications. We do basic needs assessments and referrals to other agencies. So.
And what percentage of your patients are adults and children? Do you see higher proportion adults or?
Absolutely. The bulk of our patients are between the ages of 18 and 64 and a half when they get Medicare. Fortunately, many of the children in Pennsylvania have CHIP. More recently, that's been a struggle because the undocumented have found their way to the center of the state, and they have children with them who don't, for various reasons, don't have insurance. We do an annual Give Kids a Smile and Vision Day. Ours was a week ago Friday, where we see uninsured children for all of their vision and dental needs in one day, and then they get referred if they need to come back. So the Amish will fall into that. Their children tend to not be insured, and we then work with them, the parents, to try to get them insurance. So,
Thank you for highlighting the importance of dental. I think if you have good dental care, it reduces healthcare costs.
It does, and I think you heard that across the table.
Absolutely.
And not just as far as the health issues, but the esteem issues and the employability. We do something called dialing for dollars, where a patient, we don't have the finances to provide denture services, but we work with churches and other agencies that will give a certain amount of money if the patient saves, X dollars for their dentures. As you can imagine, in our dental clinic, we do a lot of emergencies, a lot of extractions. The children on Give Kids a Smile a Day, who come in with their mouths totally blown out and have to be anesthetized to have their teeth either pulled or filled. It's so sad. So we try and do a lot of education to break that poverty cycle that exists in dental. The patient thinks, well, my mom and dad had dentures when they were 40, so it's okay that I'm losing my teeth, and they're not teaching their children to brush their teeth. So we work with the YMCA backpack program to get toothbrushes and toothpaste into those kids' hands and try and educate them about the importance of keeping your teeth, something as easy as brushing your teeth. So.
Thank you for what you do. Thank you so much.
Thank you, Cheryl, for being here today, and I appreciate your presentation here. I think the one thing that obviously comes out of a lot of this is the importance of the rural access to care, obviously, and the telemedicine, obviously, and the opioid crisis, which we're all dealing with. But I do appreciate your testimony. I would have questions, but I think it's kind of redundant from Senator Baker. I did want to, just in some closing remarks, recognize some personnel and staff here from Corey Hospital. You folks traveled a long way to be here, I know, because you're only like 30 miles from me, from Warren County. So thank you for making the trip down. I truly appreciate your presence here. And everyone on the panel. This was very informative. And the rural legislators here in this building, we appreciate everything you do to provide access to our folks in rural Pennsylvania. You play a very critical role in their lives, and we know many times without reimbursement and without the donations that you receive, those folks would not be receiving the care. So I say thank you to all of you for what you do to our folks and for our folks in rural Pennsylvania. Thank you for being here today.
Thank you.
Senator, did you have any? Right, and Lisa, thank you so much for everything that you do in putting this together. We truly appreciate your role in all of this. So thank you for being here today.
My pleasure. And thank you. We're so pleased to be able to work with you in your role as the chair of the House Health Committee. And Senator Baker, thank you again for being willing to serve this year. My thanks to all of the speakers for their willingness to put together some very, very good comments, and for coming down, and for all of you who were able to be here. So again, thank you so much, and we'll look forward to seeing you at the 2019 Rural Legislative Briefing. Take care now.
Thank you.